we are going to discuss some of the risks associated with the nursing management of labor and birth. Dystocia is defined as abnormal or difficult labor. It can be influenced by many factors, both maternal and fetal. It is said to exist when the progress of labor is deemed not normal and is characterized by a progression that is slow and fails to progress. Dystocia occurs in approximately 8 to 11% of all labors and is the leading indicator for cesarean births in the United States. Because dystocia cannot be predicted or diagnosed, the term failure to progress is used. Early identification of any of these risk factors and prompt interventions are imperative to minimize the risk to the woman and the fetus. Dystocia can result from problems or abnormalities involving 4 out of the 5 P's of labor. Hypertonic uterine dysfunction occurs when the uterus never fully relaxes between contractions. This pattern is seen in early labor and affects nulliparous women more than multiparous women. Hypotonic uterine dysfunction occurs during the active labor when contractions become poor in quality and lack sufficient intensity to dilate and efface the cervix. The major risk with this complication is hemorrhage after giving birth because the uterus cannot contract effectively. Arrest disorders are complete cessation of progress, and protracted disorders are slower than normal progress. Precipitate labor is labor that is completed in less than 3 hours from the start of contractions to birth. Any presentation other than head down and anterior facing increases the probability of dystocia. Persistent occiput posterior is the most common malposition, occurring in about 15% of women in labor. Some factors frequently associated with breech presentation are multiple pregnancies, more than 5 births, pregnancy over 35, placenta previa, preterm births, among others that are listed in your book. Multifetal pregnancy refers to more than one fetus in a pregnancy. Macrosomia is when the newborn weighs 4,000 to 4,500 grams or more at birth. It is associated with later life obesity, diabetes, and cardiovascular disease. This is a major increased risk for postpartum hemorrhage. The increase of shoulder dystocia is due to the increasing birth weights. It is considered one of the most anxiety-provoking emergencies encountered in labor. Some structural abnormalities can include hydrocephalus, ascites, or a large mass on the neck or head. Problems in this area are related to a contraction of one or more of the 3 planes of the maternal pelvis: inlet, mid-pelvis, and outlet. Contraction of the mid-pelvis is more common than inlet and typically causes arrest of the fetal descent. Some obstructions can include swelling of the cervix or swelling of the tissues. Problems in this area can lead to uncoordinated or increased uterine activity and myometrial dysfunction. In addition with the assessment, you would want to assess fetal position using Leopold maneuvers to identify any deviations of presentation or position. The management of the woman with dystocia, regardless of the reason, requires patience. The nurse needs to continuously monitor the woman's progress of labor through cervical dilation, effacement, rupture of the membranes, fluid balance, and fetal well-being. He or she is also a major role in preparing the woman and her family for the possibility of a cesarean birth if labor does not progress. Employing physical comfort measures can promote relaxation and reduce stress. Another role of the nurse is to educate the woman and family about dysfunctional labor and its causes and therapy. Providing encouragement, keeping the woman and her family informed of progress are ways for the nurse to promote empowerment. Preterm labor is defined as the occurrence of regular contractions accompanied by cervical effacement and dilation before the end of the 37th week of gestation, and if not stopped, it leads to preterm birth. The rate of preterm births in the U.S. have increased 35% in the last 20 years. They account for 75% of neurodevelopmental disorders and other serious morbidities, as well as behavioral and social problems. Tocolytic therapy will be discussed on the next slide. At least 24 hours is needed to become effective for corticosteroids. This therapy is used as an attempt to delay birth and thereby reduce the severity of respiratory distress syndrome, among other complications associated with prematurity. It is used to delay pregnancy 2 to 7 days. The woman requires close supervision when these drugs are administered. There are more contraindications listed in your text. Risk factors are listed in box 21.2 on page 812. A couple of the signs are low, dull back pain, feeling of pelvic pressure or fullness. The others are listed on page 812. Fibronectin is a glycoprotein produced by the chorion. It is normally present in cervicovaginal secretions up to 22 weeks of pregnancy and again at the end of the last trimester. It is also present in cervicovaginal fluid prior to delivery, regardless of gestational age. The test is a useful marker for impending membrane rupture within 7 to 14 days if the level increases to greater than 0.05 micrograms per milliliter. Cervical length varies during pregnancy and can be fairly reliably measured after 16 weeks gestation using an ultrasound probe inserted into the vagina. A cervical length of 3 centimeters or more indicates that delivery within 14 days is unlikely. Teaching guidelines to prevent preterm labor are listed on page 814. If therapy is unsuccessful in stopping uterine contractions, the nurse will support the couple through the stressful period and help prepare them for the birth. As the placenta ages, its perfusion decreases and it becomes less efficient at delivering oxygen and nutrients to the fetus. Amniotic fluid volume also begins to decline after 38 weeks. Maternal risks are mainly associated to the large size of the fetus at birth, which increases the chance of cesarean birth. The perinatal mortality rate at more than 42 weeks of gestation is twice that at term and increases sixfold and higher at 43 weeks and beyond. Daily fetal movements, non-stress tests twice weekly, amniotic fluid analysis, and weekly cervical measurements are assessed. In addition, the mother's understanding of the various fetal well-being tests, her stress and anxiety concerning her lateness, and her coping ability and support networks would also need to be assessed by the nurse. Providing reassurance about the expected time range for birth and the well-being of the fetus based on the assessment tests give the woman opportunity to verbalize her feelings openly. Teach the woman and her partner about tests required and reasons for the test and explain the possibility of induction. All of the care in the intrapartum period would continue until the woman gives birth. The induction rate is at an all-time high in the U.S. and has contributed to the increase of cesarean births. Continuous electronic fetal monitoring is necessary. Most common indication is prolonged gestation. Others are listed in your book. The Bishop scoring system on table 21.2, page 817, is used to assess cervical ripeness. Risks associated with mechanical methods include infection, bleeding, membrane rupture, and placental disruption. Risks associated with the surgical methods include umbilical cord prolapse or compression, fetal heart rate deceleration, and client discomfort. Pharmacologic methods have been found to be highly effective. It is contraindicated for women with prior uterine scars and should not be used in women attempting vaginal birth after cesarean. Oxytocin is not used until after the cervix has been ripened. Most common adverse effect of oxytocin is uterine hyperstimulation and can lead to fetal compromise and impaired oxygenation. Contraindications include a prior classic uterine incision, uterine scar, contracted pelvis, and inadequate staff or facility if an emergency cesarean birth in the event of uterine rupture is required. The patient must be advised about the risks as well as the benefits. The physician or nurse practitioner and operating room must be immediately available according to ACOG criteria. It is considered when fetal death occurs after 20 weeks gestation but before birth. The devastation can last for years and can cause severe psychological stress and emotional problems. Once fetal demise is confirmed, induction of labor or expectant management is offered to the woman. The demise is associated with post-traumatic stress disorder and anxiety in a subsequent pregnancy. Prolapse usually leads to total or partial occlusion of the cord. The cord is the fetus's only lifeline, so perfusion deteriorates quickly. Risk factors include malpresentation, growth restriction, prematurity, ruptured membranes with a fetus at a high station, and multiple gestation. Often the first sign of cord prolapse is a sudden fetal bradycardia or recurrent variable decelerations that become progressively more severe. Placenta previa is when there is placental implantation in the lower segment of the uterus. Implantation over or near the cervical os inevitably results in spontaneous placental separation. Risks include previous cesarean, advanced maternal age, multiple gestation, and cigarette smoking. Placental abruption occurs in about 1% of all pregnancies throughout the world and is associated with significant perinatal mortality and morbidity. Risk factors include preeclampsia, gestational hypertension, seizure activity, trauma, among others listed in your book. Uterine rupture is rare and often catastrophic complication with a high incidence of fetal and maternal morbidity. Onset is often marked by sudden fetal bradycardia. A few other risk factors include prior cesarean births, malpresentation, and crack cocaine use. Because the presenting signs may be nonspecific, the initial management will be the same as that for any other cause of acute fetal distress. Amniotic fluid embolism is a rare, often fatal event characterized by the sudden onset of hypotension, hypoxia, and coagulopathy. Occurs when particles of debris enter the maternal circulation and obstructs the pulmonary vessels, causing respiratory distress and circulatory collapse. These may be used to apply traction to the fetal head or to provide a method of rotating the fetal head during birth. The use of forceps has declined in popularity because many obstetricians are not trained to use them and are rarely used in practice today. The vacuum is placed against the occiput of the fetal head, pumped to increase negative pressure, then pulled. Major indication for the use of either is a prolonged second stage of labor. Both pose risk of trauma to the mother and the newborn. Prevention is key to reducing the use of these techniques. All of the material was referenced from Chapter 21 in your Ricci book.